conceive of this particular session as an opportunity for people to begin to think about what the Mental Health Association of Southeastern Europe might become. I'm struck by a number of things from the presentation that I would use to start this conversation. What's striking to me is the level of problem from a policy point of view faced by these three countries and by the region generally. What's amazing to me about it, however, is that while the degree is extreme, the substantive areas are very similar. This could have been a presentation with different numbers in the United States, which is comparatively enormously well-resourced. It has a long tradition of policy development in public mental health. And while I can say that we've made quite a bit of positive change and have had reforms that have made things better, we have a problem with heroin abuse in the United States that's driving the conversation. In the United States, it's complicated by the use of synthetic opioids like fentanyl, which are causing a catastrophic level of overdoses, as well as the underlying rate of both prescription opioid abuse that leads to heroin. So we could have the same conversation. We could have the conversation about the misuse or inappropriate use of the criminal justice system as a place for attempts at psychiatric treatment because of the numbers of people with mental disorder in the criminal justice system, in prisons and jails. We could have the same conversation about the low proportion of health care that's allocated to behavioral health, even though the need is very high. We could talk about the maldistribution of service providers, that they tend to be in high population regions around medical schools, and that the rest of the country is not available. We could talk about the fact that there are models of service that are available in a few places and not available everywhere. So that while on the one hand the degree is so much worse here, as your presentation has illustrated, compared to the rest of Europe, compared to the World Bank, and compared to the United States, the substantive areas are the same. What also has struck me is that the best news that I have about the international or the global situation is that for whatever reason, and I haven't really thought through why, we actually have very similar ideas about what we should do, about what a model mental health system should look like. So that's something of an advantage. We don't have to disagree that what people in Bulgaria want to see in terms of mental health services is entirely different from what people in Romania would think should be. Now, the ability to achieve the objective may be different. So where does that leave us? When we have the beginnings of a structure to bring together people who recognize that there are limitations, that there are problems, and have a growing common vision of what the services should look like. So that's an opportunity. We've convened this group for the second time now annually. Some observations. This is a group primarily of younger people, earlier in their career. As I understand it, this is a tremendous opportunity to do things differently from the way things have been handled historically. As I understand it, the leadership in the professional community has not been moving in the kind of direction that you envision as being the best way to reform services. And that this meeting and the formation of the Mental Health Association is a statement, an important statement in a way, that we want to help, we wish to be influential, we want to make a difference. And if we're not going to be led into this fight by our senior members of the professions, then we're going to do it ourselves. We have to decide what exactly we'll do. The success of convening a second Congress is a sign that there is a need to do this. There's a wish to be sharing ideas to get together. But I think it's time to think about what else might happen. So as I look out, while I could not say for sure that every person in the room here was here last night to hear the 2-minute history that I provided for the Mental Health Association in the United States, I'm going to repeat that very briefly and talk about what has become of advocacy in the United States to see if some of those examples will stimulate some conversation. And then I'll stop. I'll ask you members of the round table, to see if you have some thoughts. And then see if there are other thoughts from the audience. I happen to know that there are people in the audience that I've spoken to who are participating right now in certain aspects of reform advocacy that might be opportunities for reform or for action from the Mental Health Association of Southeastern Europe. So let me just repeat that more than 100 years ago in the United States, 2 academic professionals, one, William James, who was a Harvard philosopher and early developer of the field that became known as psychology, partnered with a physician, neuropathologist from Europe, Adolf Meyer, who was primarily a researcher, but very involved in clinical work. He was a clinical investigator. So Meyer and William James were recruited by a former patient named Clifford Beers. And as I explained last night, when he was at university, he developed the first of many episodes of bipolar disorder, mania, and in a manic state, jumped out of a window in the university several stories high, injured himself badly, was hospitalized. He had a series of hospitalizations in private and public hospitals. The conditions in most of them were deplorable, but in one where he finally received humane, effective care, he came from this experience and wrote a book called A Mind That Found Itself, about both the adverse experiences he had and the positive experiences. And he joined together with William James, and Adolf Meyer, and they founded this organization. Now, let me plant the first seed with respect to the way an association can be effective. At the time of its formation, the Mental Health Association in the United States, this national committee, developed the idea that as a national committee, it could be most effective if it had a series of local or regional committees. In fact, the formation first of the National Committee began in one state, and it was a state committee, and then they formed the National Committee. And before too many years went by, every state in the United States had the development of a committee for mental health reform, a mental health association. And these members would get together for a national organization. Now you have to remember that most of the states in the United States are larger than each of the countries that you just presented. I mean, the state of Maryland, where I do most of my work, has 6 or 7 million people. It's one of 50 states. So we're talking about a different kind of scale. But imagine the United States as Europe, really. There was a theory of reform that grew out of the Mental Health Association that shaped the way we thought about mental health services in the United States for more than 100 years. And that was the idea that is very attractive from public health, that early intervention in the treatment of mental disorders will prevent people from developing chronic illness. And this was the goal, of course. It may be tragic to have an acute mental illness, but that tragedy is made worse if it becomes chronic and the person never recovers. Didn't have Beer's experience of a mind that finds itself. Well, this idea prevailed for more than 100 years, that early treatment would prevent chronic illness. And there were a series of reform movements in the United States starting in the early 19th century that said, well, we'll treat people in asylums early in their illness and they'll get better. But it didn't happen. People still became chronically ill. But the idea persisted, and at the turn of the 20th century, there was a theory of early treatment, and people were treated in medical centers. And it expanded treatment, but it didn't work. If we move ahead to the 1960s, people were being moved out of mental hospitals in large numbers, but there weren't adequate services to treat them. Two separate movements began in the United States, in addition to the Mental Health Association. In the late 1970s, and right around 1980, families were increasingly burdened by the return of patients from state hospitals to, quote, live in the community. And suddenly families were put in the position of not only having had what for them was the tragedy of a family member develop a serious mental illness, but now the treating hospitals that they had depended on to look after their family member were now sending the patient home. Family members started to think, who's going to look after my family member if they continue to be ill, if they're not going to be provided with a place to live and treatment in a hospital? And in the United States, in addition to the Mental Health Association, was a group of family members. They organized into what in the United States was called the National Alliance for the Mentally Ill, now the National Alliance on Mental Illness. It's been an incredibly powerful force for an advocacy activity in the United States. The Mental Health Association continued to be focused on early treatment, prevention of mental disorders. Well, the family groups became involved in their own reform. They were quite antagonistic in 1980 towards the Mental Health Association. They said, this model is not working for us. Our system of mental health services began to focus so much on acute illness that people who were disabled were being neglected, and now they were being sent home. And in fact, the National Alliance for the Mentally Ill led a movement in the United States at the state and national level that totally reformed mental health service delivery in the United States, moved it away from the vision of community mental health that had been championed by the Mental Health Association, that focused on bringing more and more people who had anxiety and depression into care, expanding the caseloads, with the idea that if they were treated, we would have fewer people who were disabled. The members of NAMI said, enough. While you are expanding services for people who are acutely ill, people who are already disabled are being neglected. Is one model of national reform that was very successful. In the United States, it was in opposition to the Mental Health Association. That is not to say that a mental health association here in this region couldn't lead a similar national effort to reform services. But we'd have to agree on what is the target of opportunity. the tactics that one would select. Another similar advocacy came from the government itself in the United States. The National Institute of Mental Health in the late 1960s and early 1970s developed what they called a model community mental health center. It decided that what it could do better than anyone else was to show how science and what we knew about effective treatment could be put into action. And they actually developed, from the National Institute of Mental Health in nearby Maryland, which is the state that I referred to earlier, where the National Institute of Mental Health was located, they developed what was called a model community mental health center. And practices that were being developed in the research community were tested out and implemented in the real world, and they were studied there. It was called the Mental Health Study Center, but it was a community mental health center affiliated with the university. So in the first instance, NAMI was a national force to change the focus and the emphasis of mental health services. In the second instance, the reform was to develop a model service as an example for the rest of the country to follow. These are just two examples. At about the same time as family groups were organized, patients organized as well. Service users, as I guess the British term that's used more widely in Europe. Service users became organized. They said nothing about us without us was their political slogan. And slowly they influenced the way, at least in the United States, we have begun to think about service delivery. Not only in the development of policy should people with real life experience be involved in thinking about policy, but now the world of service has had the benefit of service users as caregivers, as members of treatment teams. We've even recognized that service users can be part of the decision-making process in a shared way in service utilization. So every service user is a partner in service delivery. These are all things that came from advocacy, in this case from service users. So I wanted you to see that if we have similar problems, even if the magnitude is different, that we can learn tactics and strategies from our experience in the United States, where there is quite a lot of advocacy. But I know just from the years that I've been interacting here and talking to people in the audience here this morning, that there are advocacy groups as well that could be partnered with. We're primarily a professional organization at this point, but there could be opportunities. So I want to stop now with my own remarks, give you a chance to just reflect if you have anything you want to say, and then throw it open. I know that Heinz Kochnig has an experience with a family users group that he's been doing in Cluj. And I know, for example, I'll put her on the spot, but Lisa Dixon is extremely active in our National Alliance on Mental Illness in the United States, and may have something that she could add. But I really think over the next 2 days that we'll have an opportunity to think. We'll use the rest of this session to see what people are thinking about.
It's difficult to do this here because the healthcare system, mental health system, still one paternalistic way, where the client, the users, is not allowed to have his own view about therapeutical decision or something like this. The second point I want to be focused on, it's related to the other organization. I was finding out from Heinz Kochnig here that there is another effort to put together family members in Romania. are many NGOs that even in the internet era, when you could send an email message, there is a lot of communication. And I don't know why, even for this conference we invited representatives from other associations. They're still reluctant to collaborate and to make common strategies in order to become more powerful in our actions. So, American model, it's a good one, and we need to feed it in our countries.
Well, let me say that there continues to be tension between the Mental Health Association, what's now known as Mental Health America in the United States, and NAMI, the National Alliance on Mental Illness. They can agree on certain things, expanding resources, but what the emphasis should be on is sometimes very different. One place where there's been more commonality of interest is in early intervention in psychosis, because it's a model that's attractive to both of these organizations. As far as shared decision-making, are you implying that the attitudes of clinicians are such that that would make it? Because there's no place like here and now for clinicians. What would stop you? Are there police that observe clinical interaction? Is there anything that would stop a clinician from engaging in shared decision-making about the choice of antipsychotic medication or antidepressant medication? You're saying they don't accept it, but there would be nothing that would stop them. There's no thought police. It's just the attitude. Thanks. Did you want to share your experience? Yes, your microphone is working.
Yeah. I'm referring to a talk I listened to yesterday. So I especially came one day earlier to see what's going on at the grassroots here. And there was a talk by Monica Cara on quality in mental health services. I don't know whether she's here, she's here. And I carefully observed her slides. I mean, it was very long and somewhat tedious. Quality of care is always a very difficult topic if you want to be comprehensive. But there were 2 or 3 slides showing that this agency you have in Romania now for quality assessment, so it's a Spanish acronym is A, something like that, yeah, where they referred to the users and carers. So they said something, it was rather quick, and maybe you can comment on this better, that users and carers have to be integrated, and they have to be, is it done? I mean, this is an association which checks the quality of care, so all these things are, when you do an evaluation, are users and carers integrated or not? And the second thing I wanted to say, you mentioned Cluj. I'm having a couple of friends there, and there's a German NGO which for some time in the northern part of this country helps hospitals to improve hospital care, and we together try now to set up a family organization there, not a user, but a family organization. And they're already having a group every 4 weeks, family members meet. And we're having a meeting next month, there even again, and we try to somehow influence them to come together, speak out. It's difficult here, but I just wanted to mention that officially, somehow in this association, it's already recognized that this is an important part of the whole mental health. So I'm not sure that I understood it correctly, but they have some kind of initiatives which may be sanctioned officially.
Could you elaborate? Monica Cara. Hello? You'll need to speak right into the microphone. I think you practically have to swallow it to be heard.
Yes. It's not an agency, it is an authority, a national authority for quality management of quality in healthcare system, and they are focused about patient safety in general, but they are focused on psychiatric patient, and I think this is a starting point for mental health association to be partner with this authority for maybe making things better in our system. Thank you.
So do they have a voice for change?
I think they do, because all health services that are going to be in contract with the national founding, they should make this accreditation process here in Romania.
I see. So that if there are lapses in quality,
Yeah.
they have political strength to make change?
Yeah, because they are under government.
Government authority.
Yeah.
Okay, good. Maria, you were going to?
Yeah, I would.
Sorry, can you say how this institution is called? The name.
What's the name?
What's the name?
In English, they call it National Authority of Management in Healthcare System.
Management healthcare. Okay. So Mihai says the leader of this is a former Minister of Health here in Romania. Okay.
Thank you. Thank you, first of all, for the presentation. And I would speak for Romania. I think our main problems would be the prevention and the community care, which is very well developed, you should know, on paper, but was never properly funded and put in practice. That would be good target, and I would think that prevention would be much more important. I think that that could be a target, that could be an objective we could find. But concerning the family of patients and involving them, I wouldn't blame the clinicians. I think there were a lot of clinicians which were involved in a group of patients. I did that a long time ago and during many years, and they are still going on groups. Of course, it is also an attitude in our country. People starting becoming more vocal, but that takes time. And it is true that people who are stigmatized and family of people stigmatized still have a problem with that, but there are some associations and patient associations which becoming more important. The truth is that the gap between their voice and the ministry or the authorities, that's an issue. I mean, I don't know, maybe clinicians could have a professionals could help, but of course the voice from the patient and the family should get to the authorities, and I think that's again the gap we could address to maybe.
Okay, thank you. Lavinia.
I was thinking about a possible practical solution. If we are writing a project, the three of these countries, Romania, Bulgaria, Albania, or even Croatia or Serbia, targeting the development of one pilot center in each country who focus on communitary mental health services.
Which kind of mental health services?
Communitary.
Oh, community.
Communitary. Writing a project to get financial resources, European funds, and develop one pilot center in each country. And I don't know what means this. Maybe building a community center or developing mobile teams.
Is this a way that change happens in this region? I wouldn't know. I mean, some places building a model service is an excuse not to do anything anywhere else.
But it's true.
In some places, having a model is a way to show to government that an idea can be brought to reality, and it's the seed to propagate an entire field of community mental health centers. So you have to really know.
I have no trust in such policies.
In which policies are they? So you have no trust that having the model that you proposed would make any difference for, I'm not understanding your response.
Government policies.
I see. So the problem, and I have to say that I do come away every time I interact with a sense of profound skepticism and frustration that good ideas are stopped by bad politics. That's where your response comes from.
We start. Demonstrate that such a center can work.
I mean, there are lots of theories that you could put forward for why this idea, that as I illustrated a similar example in the United States. I have to say that this model community mental health center from the National Institute of Mental Health was not unusually persuasive compared to other initiatives, but it was a model. It had its use. But NAMI was much more, the family group was much more powerful in its influence over where policy went in the United States. But this frustration that you experience, that the government and politics are unresponsive, are there no examples of popular force, of people's kind of effort that's changed public policy in spite of difficult politics? I would hope that there were examples. Vladimir.
I'm not so optimistic here in Balkans because I can give you another point of view. Our Ministry of Health invited European Psychiatric Association to assess and make a report how to improve our mental health care system. And we have very strong resistance from Bulgarian Psychiatric Association against this measuring of the system. They only say, give us more money, we know how to use them. And they against the report because they are afraid that the proposal will be to cut the number of the beds. This is the reason I'm not so optimistic here in Balkans.
All right.
It looks like we should be involved in advocacy, but
That's the message.
but the traditional means and ways maybe have some history in the last 20 years in our region with successful failures. 10 years ago, you could speak for at least 4 or 5 family or user associations in my country. But they step by step have been alienated from the mainstream discourse of reform, which has been embodied not only from this ideologically formal international, but also from even many of us being enthusiastic, trustful, then old, terrible ways of having the system of care have now clear and efficient and effective system of care on community mental health system described so often. Users and family associations were all the time putting the finger to the need for more services, and especially the need for more services for severe mental health issues. What was happening step by step was increasing somehow services, but for minor mental health problems, if I could put it like this.
Well, this was the example that I gave of how the Mental Health Association was influential in expanding services on the acute end.
What we are having is a phenomenon of today. It is that a huge number of people are at prisons, and I doubt a bit that this is due to abuse of let's say, the criminal justice system. It is also kind of push and hidden tools of the family to get rid of some of those family members, seeing that there is no more space, any channel or a window into the health system of care. Which means it transforms the attention, resources, and the way of moving ahead for an entire community, which is the community of the severe mental health patients. Those supposed to be the fighters. They have no more hope that it could be solved with the tools of the public citizenship. And they try to find other means for solving their problem. It's a shelter. And it's a shelter 365 days a year. Are the conditions in these kind of shelters very bad? No, because if EU is putting pressure on the quality of life in prisons, there is not at all any pressure on quality of life in psychiatric hospital or in mental health system of care. We might give some arguments which maybe need to be tested or no, that this movement in the countries which have faced an increase of their voice and now going down, it's coming to a point of hopelessness, which doesn't mean that we should be pessimistic. It's only maybe to think about other tools of advocacy and how the role of advocacy might start again, like it happened in the 90s, through the professionals. And then maybe be more able for us professionals to take some lessons from their perspective, but their hopelessness also.
So if I understand, the argument is that while things are difficult now, there was an experience, it does create an opportunity for change. People recognize that they're difficult. There's some frustration, but you have an example from 25 years ago where professionals, an organization like the Mental Health Association of Southeastern Europe, might once again be influential to pick a target for change, whether it's to improve the quality in prisons or to find diversions to keep people out of prisons and find an alternative. But that might be a target of opportunity, But that change might happen if you re-examine what was successful 25 years ago. Is that a fair restatement of what you said? Correct it then.
Considering that all the movements in this part of the region were maybe too much ideologically driven by this community mental health system of rhetoric, of discourse, maybe not very much or deeply connected with the local reading of the needs of the family.
I want to share some additional information which might explain us a little bit why, for instance, in Romania you have this national authority looking on quality aspect and the things you were reporting on it. And then I have to refer to international protocols and conventions. And maybe, I didn't check this now right now, these conventions haven't been ratified by the United States government. But they were all produced by the UN. And one is coming from 1982, and it's the Convention Against Torture and other cruel, inhumane, and degrading treatment or punishment, called OPCAT. And this OPCAT typically referred to prisons. But it was amended in 2002 by the UN in an optional protocol. And it is in vigor since 2006. And this optional protocol called OPCAT has been ratified in Albania, in Romania, in Bulgaria, in Austria, in many EU-European countries, because also the European Union is a driver behind it. And this OPCAT refers that the situation of people not only being put in prison looked at their quality and their human rights inside, but all the people who are living in institutions run by the states, including hospitals, including mental health hospitals, including homes of people with intellectual disabilities. And so we have commissions in these countries who are monitoring the situations in terms of human rights in these, and then they develop some plans of quality assessment in these areas. What I don't know on what level these commissions are functioning in the various countries, and whether there is a network within Europe of these national OPCAT commissions to make stronger experience and exchange on this. I think this is a very crucial point.
Okay. May I say, I have been very much involved with the center in Albania, being part of the network of the centers called Against Torture. So this convention was produced by the OPCAT, an optional OPCAT was produced by UN, and then they had to reach the number 20 of the countries being ratified. This, due to the rules of UN, this 20 it's a golden number. And then this networking organization from Copenhagen was trying to lobby in different countries for securing that the respective states could be active and could sign this optional product. And this is the time when our actual president was Minister of Foreign Affairs. Considering this organization was quite, let's call it, important, then when they arrived in Albania, they organized a meeting with the Minister of Foreign Affairs at the time, lobbying for Albania to ratify, so sign this optional protocol. And they were having a resistance in many of the offices in the country to say, yes, but we cannot, it's impossible for this and that and that. But in fact, the Albanians had already signed it 2 months before. And this is due to the fact that we could sign everything on paper. When it comes to making the implementation, it's completely another story. So Albania is the second country in the world signing the optional protocol. Yeah. Which means that when it comes to the missions of making the monitoring, it is the reasons why those 280 people being in the prison now, they will go out of the prison, it will be a psychiatric hospital, and then a new building of around 11 million US or euros will have to be reconstructed, and all those budgets and numbers will refresh the data of the Ministry of Health, presenting in 3 or 4 years important developments in the system of care.
One remark to this. I know that Albania was one of the very early countries signing this protocol, and I was really amazed when I was reading this many years ago. And now what we heard, I'm not an expert on what is going on in Romania in this context, but there is a government agency set up, and they are reporting, they are monitoring. On what level, I cannot assess this. But this fact that in Romania, as one example, is now active, taking the first active part in this context, is probably linked to its membership in the European Union. Because when Albania might join the European Union once, they have to adopt a practical action plan for and set up the commission and doing this work. That is one of the prerequisites if the members coming joining the European Union, looking for the human rights issues in many contexts in the country. That is not that everything is changed within 2 years, no? So, but this is the first start to do it. No?
Well, this will be a difficult path. There's no question about it. The purpose of this roundtable was to begin the conversation. We'll have a similar session on Sunday morning to revisit, to share some thoughts that you might have had over the 2 days of the meeting, talking amongst each other. The first step will be to sign whenever it is that we agree to do. But I submit that what's important is to have a clear objective, one that we can achieve, one that is appropriate for a professional organization like the Mental Health Association to do, that we have a plan for achieving it, that we try to pick something that is achievable so that it's a platform that we can build on for the future. Anyway, we have a break now in the session, and we'll reconvene for a lecture. And let's think about things, let's talk amongst ourselves, and we'll reconvene on this